Happy New Year and welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist. We bring you this podcast every Wednesday and have for 3+ years as veterinarians and technicians to make you the best you can be in your dentistry service as a team. Let's get started with a case this week. And this is a case that kind of surprised me about 18 months ago when I recognized that a lot of us in general practice are not familiar with this entity. And it's not super common, but you will see it. And my guess is that you've probably seen it off and on throughout your career if you don't recognize what this is and just missed being able to identify it. And it's pretty critical that we catch these early in the course of progression because they are very painful for the patient. And as we know as veterinarians, dogs and cats, and this is a dog case, dogs and cats do not readily exhibit pain in ways that we think they should based on the degree of pathology. So they can be really painful and the owners have no idea that they're painful, especially if it's a chronic case where the patient has had to live with that discomfort for a period of time and it slowly progressed. So a lot of the changes they attribute to the patient are not specific to pain. It's more in the case of something that is many months to years in progression, which this can be and often is, attributed to aging. And the patient gets a little slower, they're not eating as much, they don't play with the toys that they played with before, they may be sleeping more. So all of these things are attributable to old age or other things or just gone unnoticed. And it's very unfortunate, as we know, because we see in general practice some patients that have conditions of varying systemic manifestations that may not readily present themselves as pain, that are subtle, that again, the owners just do not pick up on. And so that is where we come into this entity in being able to recognize it, being able to treat it or make recommendations for referral for treatment, depending on your level of skill and expertise in dentistry and dentistry surgery in particular. And with that, we will go through the description of this for those of you who are listening on the podcast, and we'll also have images for those of you who are in YouTube that are watching this today. So with that, we want to describe what this looks like from a general perspective and describe how the patient might react in the exam room. Many of these patients do not allow for oral examination readily because they're so uncomfortable. And again, the owner may not know this, may not be aware that their behavior is due to pain because most pet owners are not consistent or don't at all lift the lip up to look at the gum tissue and the teeth. So they're totally unaware when they present these patients in many cases. So this may be just a general exam on an annual examination in your practice with a patient. Usually these are small breed dogs, Alex overrepresented, Maltese, miniature poodles, any small breed are overrepresented, but it doesn't have to be small breeds. It can be any breed at all, any size. So the patient is historically, but not all the time, very reluctant to oral manipulation and may be perfectly fine with examination of other areas of anatomy, but when you get toward that head or get into trying to get in the mouth, they're very adamant about letting you get in there. They may even be aggressive. Most of the time, depending on the original demeanor of the patient, they're going to move their head and try to get out of the way so that pain response is not exacerbated by manipulation. So the first thing that we generally do when we do an oral exam is carefully lift up the rostral lip. And if we do so, if they have this condition that's associated with the maxillary canines, which is common, and usually it's bilateral in all of these presentations that I am describing, when you lift that lip up, you're going to see a dramatic inflammation present on the mucosa adjacent to the crown of the canine tooth when that lip is at rest. And this can present itself as an ulcer that is literally sloughing. And if you're watching this on YouTube, you can see that what I'm describing verbally is depicted in this image of this patient, where you've got that area that's a little whitish right underneath that glove. And that is in the center part of that severe inflammation. And that's just an ulcer that's present that will slough upon manipulation. And underneath that, sometimes we're right down into the musculature. So it's very painful for these guys, especially with that presentation. And again, you may not be able to see this in the exam room. So case in point, if you have a patient that will not allow oral manipulation, especially if they present for any kind of historical evidence that they are painful from the mouth, they're dropping food, they are not eating as much, they may use their front limbs to massage their face, they may rub their face on the carpet. These are things that you want to ask pet owners, pet parents, to see if indeed some of these things are present and they're just not relaying that in their observations and their history. So when you are presented with this in your practice in the exam room, that is one thing that keys you in to maybe these are patients that need to sedate and get a really good oral exam. And if you are seeing any signs whatsoever from the oral cavity and the patient won't allow oral manipulation, that is an indication to sedate that patient and look in the oral cavity. And this can be done in a couple of ways. You can do it that day. However, most of these are going to require some pretty significant care, including diagnostics, which would be dental radiographs. So it might be best to get this patient on some type of analgesic preparation or preparations, and we'll talk about that in a minute, in order to provide them relief until you can get them back and schedule an appointment that is a general anesthesia versus sedation, because most of these are going to require that. They're going to require long procedures, at least to get the diagnosis and radiographs. So that being said, if the patient allows you to look, you can see this characteristic lesion if the canines are affected. The other common presentation is not so readily visible. We commonly see this affecting the caudal oral mucosa adjacent to the cheek teeth. So the fourth upper premolar and the lower first molar caudal, the tissue adjacent to those are affected. And with that, you can see in this image, if you're on YouTube, the proliferation back in the commissure area adjacent to those molars that are present, and the tongue's in the way. I'm not sure if those lower teeth are still present, but you can see how severe that is. And sometimes when we do approach these patients in order to get to those back teeth, we have to do a commissurotomy. So we take and we cut that tissue to open the lip, because it's like cardboard. There's no resiliency there. So when we attempt to get our exposure to, especially the back molar, it's very difficult to do that because there's no resiliency in that tissue. So opening it up and then suturing it back, mucosa to mucosa and skin to skin, is the way to go on these. All of these things that we're talking about right now, in general practice, what I've discovered is that in teaching our wet labs and in talking to practitioners in general in some of our meetings, like our mastermind meetings and our online groups that are associated with the Veterinary Dental Practitioner Program, many of them, especially if they're new to the program, have really no idea what this is. So that being said, you have an opportunity to up your game in veterinary dentistry to the point of being one of the best in the world in general practice if you choose to do so. We are opening up the Veterinary Dental Practitioner Program on January 12th, and I invite you to come to that meeting and participate. And if you feel that this is something for you, we are taking 12 veterinarians into that program. And this program is not only for you, it's for your entire staff, especially your dental and anesthesia technical staff. And it's a year-long program, and it's a wonderful commitment with a great group of individuals that are very supportive all around in all of the media that we use to make this platform very effective and a wonderful experience for the veterinarian. The end result is that your whole staff and you are trained at a level way above where most general practitioners are trained. And so you can go into these cases, you can understand them from the origin of the exam and be able to make a quick diagnosis, be able to perform the correct treatment, and be better for your patients and better for your life, your career, and all around with your practice. So I encourage you to go to ivdi.org/VDP, as in Veterinary Dental Practitioner Program, VDP, ivdi.org/VDP, and register for that. We're going to have that at 10:30 a.m. Eastern, Sunday, January 12th. So moving on to this, being able to recognize this and see this grossly and understand how the patient reacts in the exam room will get you to the diagnosis. This is one that's not necessarily made with histopath. It's pretty pathognomonic when we see these signs. And this condition is called CUPS. In the past, the name has been changed. The CUPS stands for Chronic Ulcerative Periodontal Stomatitis. You might find that in searches. It's also now termed CCUS, or Canine Chronic Ulcerative Stomatitis. So knowing how to recognize this is super important for the patient. And I hope you take home that end result, that you can recognize these and be able to, again, either make recommendations to have them treated or treat them yourself within the practice. Going further, if you see these patients in your exam room and you cannot get to them right away, which is generally the case, the most effective thing for these guys, if they're showing clinical signs, is corticosteroids. So you want to use an anti-inflammatory dose of corticosteroids to get the most impact from one agent quickly for these guys, because they're painful. And analgesics are great, but in this case, when you've got something so painful, we want to hit the big hitters. And this allows us to get some really quick relief for these guys. So corticosteroids, you can definitely use NSAIDs without corticosteroids. In addition to gabapentin, I would suggest you use gabapentin. Since this is a chronic condition, it's an abnormal pain reaction, it's chronic pain. There's wind up in the brainstem from this through the trigeminal system and the trigeminal nucleus. So we want to make sure that we cover all bases and use multiple agents. So gabapentin plus or minus NSAIDs or corticosteroids, and that would be the basis of your pain management for these until you can get to them clinically to resolve this. Now, you may not recognize this right off. If you're in general practice and you don't have a lot of experience with this, you may be reluctant to make that diagnosis, and that's fine. So what I would suggest is going in and sedating this patient, take dental radiographs, take images for the owner so that they see the profound effect that this is having on the patient, and then plan on getting this patient back for definitive treatment if it doesn't respond to cleaning, analgesics, and polishing along with oral care at home for a period of 2 weeks. And oral care at home is going to have to be something that's non-invasive. Brushing is not going to work in these patients. So one of the things that we use is TDC, which is an esterified fatty acid. Comes in a little gel cap. You can break the little section off the top of it and squeeze it into the oral cavity. If the patient doesn't allow that, it can go on the food. And it's not only been shown through research to be extremely effective in our patients, but also mountains of evidence in humans with periodontal disease and the effect there, and systemically on joint health. So that's another thing that you can use in addition to your analgesics. Get these patients back in 2 weeks and do an awake oral exam. If there's still some inflammation, then you can pretty much bet this is cups. If the inflammation has subsided significantly, eliminate the TDC, get them back in 2 to 4 weeks, recheck them again and see if that inflammation has come back. If it has, then you can again bet that this is cups. Now, upon that original 2-week cleaning, if you have any question about this, biopsy. Send that biopsy into a pathologist with a description of what you see and have them make a comment on whether this is a possibility. And all pathologists are going to be aware of this condition. So make sure that while you're in there at that 2-week interval, after you first see this patient, if you can't get to them and you're unsure of your diagnosis, biopsy and send that in for confirmation. Then definitive care for this, the only definitive care for this is extractions. If you attempt cyclosporin, if you attempt steroids, those things are short-lived. Cyclosporin is difficult at best for anything associated with the oral cavity, although there are studies in cats using cyclosporin with stomatitis. The results are not consistent with what I would recommend that you even attempt to try, just because of the percentage of cases that respond, the blood level monitoring that's needed to maintain adequate blood levels, and the rechecks that are required for that in order to get a very low percentage response rate. So don't recommend that. The only definitive care is extraction of the teeth adjacent to the inflammatory reaction in the tissue. So if it's confined to the maxillary canines, there's absolutely no mucosal involvement anywhere else, which happens, then extracting the maxillary canines is curative. Same thing goes with any other regional involvement within the oral cavity. Again, the caudal mucosa adjacent to the fourth premolar, first molar, and caudal to that, extracting those teeth will be curative. Now, that being said, this can also be a full mouth endeavor. You may have all of the mucosa affected. That's not unusual to find that. In that case, we're looking at full mouth extractions. These teeth often are not affected by periodontal disease. You contrast that with cats with a similar condition, stomatitis, not that it has the same etiology or anything else, but just a severe inflammatory disease of the oral mucosa and attached gingiva. In that situation, you very similar presentation and very similar approach to extractions. However, this is curative. Cats 70 to 80% curative. So with that being said, we want to make sure that we make that diagnosis, make the correct diagnosis, be able to go in there confidently and extract. But back to another point that I was going to make about stomatitis. With stomatitis, those cats have periodontal disease generally associated with the stomatitis. It's almost never seen unless it's a really young cat where we have feline chronic gingivostomatitis without periodontal disease and without tooth resorption. So these teeth are not undergoing bone loss for the most part. Some of them may be minimally, but in general, when we see these guys for surgery, they are full coverage alveolus over the entire tooth root with very friable tissue, but little to no periodontal disease. So these are difficult extractions. These are only recommended if you are very comfortable with surgical extractions. And when I say very comfortable, we need to realize that these are going to take a long time. And sometimes in practice, especially if these are brachycephalic patients, I'm not going to do this all in one go. I'm going to do half the mouth, upper and lower, get the patient back and do the other half, because by the time we're into half the mouth, we're maybe 2.5 hours in. And 5 hours is for the patient is probably the best thing, as long as the patient is okay based on what the anesthesiologists tell us, that one induction and recovery is better and a long procedure is better. And we see that in humans too. You know, they do sometimes 12-hour surgeries in severe trauma orthopedic conditions, and they're not going to wake that patient back up and do that again. They're going to continue and monitor that anesthetic episode and make it so that it's as safe as possible for the patient in that regard. So if we can do these all in one go, great, but it's very difficult to maintain that level of concentration and efficacy and speed for 5 hours. You know, you get fatigued, and mentally and physically with these. And going on after 2.5, 3 hours is probably not the best thing for you, and definitely not the best thing for expediency and speed for getting these out of there as quick as possible. So breaking these up into 2 procedures, even at the specialty level, is not unheard of. So keep that in mind. You want to be able to get this done in 3.5 hours at the general practice level for one side. And if you can project and safely realize that that's a possibility and a probability for you, then and you've had good training in wet labs and you're comfortable and confident in your procedures for surgical extractions, and by all means you can definitely approach these. But for the most part, because of the tissue management, because of the severity, often these are better referred just from the experience and the speed standpoint to get these patients done as quickly and safely as possible with minimal anesthesia time. So managing these post-operatively, we want to definitely do a continuation of what we do intraoperatively and preoperatively. So depending on what you've done between the time you've recognized this and the time you get the patient in, you will want to start a continuous rate infusion of an opiate and ketamine, plus or minus lidocaine, or whatever your CRI analgesic preparation of choice is for canines. And then continue that on throughout the immediate post-op period, wean these guys off, and then continue with gabapentin for the chronic pain, and NSAID preferably, possibly a fentanyl patch or some other opiate that you're comfortable with going home because we've gone in, and even though we've preempted the pain a lot from a CRI standpoint and from a preemptive standpoint with our medications we've sent home to get this patient comfortable, we still are inducing surgical pain to these guys, and so we're exacerbating that pain response, and we want to be able to minimize that in the post-op period. And so again, preemptive and perioperative analgesics, and then analgesics to go home, as we've just mentioned. So I hope this has given you a really good overview of this condition. It's a very frustrating and difficult one. One thing that you might add to what I've talked about already today is you may see these patients that have come to you, they've maybe moved to the area recently, and they're now presenting to you for their next cleaning and prophylaxis, and they may have had dentistry procedures done every 6 months or so for several years, and these were never recognized. So that should be a red light to you that these patients are coming from somewhere else that did not recognize this, where they were cleaned and the cleaning interval is less than what we would expect normally, 6 months or so, which ideally in some of these small patients, they need to be back every 3 to 4 months anyway, cups or no cups. Or actually without cups. We wouldn't want to clean cups. So I misspoke there, but without cups, some of them need every 3 months to maintain their periodontal status before the bone loss progresses. So that patient that presents to you in that mode that you haven't seen before, but has undergone frequent prophies and still needs to have them, that's a big warning sign that this may be present. So I hope you've enjoyed this. First day of January 2025, first day of the year in 2025, actually. And I hope you have a great new year. And again, if you are interested in upping your game to be one of the best in general practice, ivdi.org/VDP, register for that live presentation I'm going to do about that program on Sunday, January 12th, coming up here in 11 days. So take care and Happy New Year.